thanks very much to the organisers. I think it's been a really kind of fascinating morning. There's been a lot of really interesting conversations. I particularly appreciated John's kind of take on it from a Canadian perspective, but it really chimes with some of the experience that we've had, and I kind of feel like we're probably that general contractor, but we're also doing a bit of the plumbing and the bricklaying as well. So starting with kind of the same question that Grania posed at the start of the session, which was kind of what does evidence-based policy making mean to you? I'm a cyclist, so I kind of thought that some people have it in their heads that it's a really well-oiled machine, it looks fantastic, everything is contributing exactly as it should, and it's maximizing the impact and the speed that can be generated. But I suppose in reality, sometimes it's kind of a bit more like this, where you're trying to bolt together different data sources and different perspectives at the same time while cycling the bike and mending it and trying to get from A to B. Now, the bike will work. You can put the wheel back on, you can inflate the tire, you can oil the chain, and you will get there, but sometimes it takes time, and sometimes our expectations is that it's going to be a bit more like the one on the right, and sometimes it's a bit more like the one on the left. So we're the Strategic Research and Evaluation Unit. I suppose we provide a kind of an internal consultancy within the Department of Health. We're staffed by members of the Irish Government Economic and Evaluation Service. So we work in kind of areas like pharmaceutical expenditure. We're currently providing some, I suppose, support to negotiations on pricing that are underway. We're looking at hospital productivity. I suppose that's been a big priority over the last couple of years. We're looking at, we've managed to transfer the NIMS data set, so we're looking at diagnostics utilisation in relation to a programme for government commitment. We're looking at avoidable hospitalisations and conditions that could be caught kind of more early in primary and community settings. We're supporting the department in the budget negotiations that happen every year. We're working with the Department of Public Expenditure and Reform on multi-annual budget setting for health, and hopefully we might be able to move in that direction. We're also designing how that funding, once it's decided at a national level, kind of flows down to the regions through a population-based resource allocation model, and then to the hospitals through a kind of reformed activity-based funding system. We have behavioural scientists in the unit, which is great. Some of them are here today. And we're really looking at maybe some of the process optimization that can occur when you apply behavioural insights, looking at the types of communications that might go from a hospital to a service user, or even the processes within a hospital that could be streamlined and made more efficient. And then, we're doing a good bit of work on bowel screening to see if we can increase uptake through behavioural interventions. And then on the workforce supply, we've done a lot of work on modelling the demand and supply of various different healthcare professionals. There should be a new strategic workforce plan published in the next few months on that. And I suppose we're trying to, I suppose it would be no surprise that the demand is increasing and the supply hasn't kept up. So it's to what extent can we live up to that WHO commitment around maybe not taking as many graduates from other countries that might need them, and trying to reorientate some of the domestic supply. But even then, the gap will probably retain in certain areas. So how can we kind of work to close that gap with other kind of policy initiatives? So I suppose we've kind of been on a journey for the last 5 years, and it's trying to understand and reflect on what we've done and maybe how that's been effective, and then maybe give it to you guys, and then you can reflect on maybe some of it might work for you, or some of it is maybe just for us. So I suppose the things that have worked for us is that we've really had to prioritize. We're a small unit. There's about 15 of us. So we can't do everything, and we kind of prioritize on the basis of kind of expenditure commitment and the potential to impact on health outcomes. So that kind of gives us a kind of a way of deciding between the different asks that we're faced with. And then we kind of started small. We tried to be useful. We'd do things that were requested from senior management or whatever. But then we built up over time, and we tried to, from those kind of small acorns, kind of develop research agendas in particular areas where we mightn't be able to do it all at once, but over time you're able to answer more of the questions that can then inform the policy approach. You have to deliver on time. I suppose it's kind of come through in the sessions how rapid the policy-making process is at times. There's no point having perfect research 2 months after a major decision has been made, so it has to be on time and on the right desk. And ideally, you need to be in the room to explain it as well. You have to work really closely with policy units. So we kind of face into the different policy units that might be responsible for different aspects of social health and social care policy. So you really have to try and build the connections with those policy units and make sure that they understand where you're coming from. You're not just trying to criticize their work and saying they're doing a crap job, but actually trying to kind of show how you can be useful to them in kind of accomplishing their objectives. We have to use imperfect data. The data, I was kind of talking to somebody there last week, and I was saying, maybe in the future we'll be able to look back and say, wow, we have all this perfect data. But that's not here and that's not now. So how do we use the data that we do have to try and inform decisions that are going to be taken regardless of whether the data exists or is on the right desk? So we have to use imperfect data. We have to make recommendations. So we are nominally the experts on certain aspects of evidence. We have to distill and actually make recommendations on the balance, with the caveats and with clarity around some of the assumptions that you're making. But what are we proposing should happen as a result? You need to de-risk publication. So when I joined the department in 21, there maybe wasn't as big a culture of publishing some of the research that was going on within the department. And there was a lot of nervousness around kind of publishing Department of Health research. So you really need to kind of sit with policy units. You need to provide really good briefing for every level of management up to the minister, to make sure that everybody is comfortable, the questions that are likely to arise are anticipated, and that everybody is kind of understands the process. But we find that the more you publish, the kind of easier it gets, because people get familiar with the thing, and they've published before, the sky hasn't fallen down, and they're willing to do it again. You need to kind of support implementation. So it's not just, there's your paper, off you go, we're finished here, the research is done. So it's really trying to understand what the implications of that research is and how you can build it into sort of the implementation phase, how you can sit with the policy units and make sure that they understand when they're getting tricky questions, or if there's operational issues that arise when you move into implementation, how do you kind of support them in that? You need to expand the research output. So it's not all about, the big snazzy publication, and we have done those, but it's also about, the short technical papers that maybe don't see the light of day. It's about publishing dashboards which take maybe some of the research that has been undertaken, extract some of the KPIs that we feel are really important, and then publish them either internally or externally, so that the research is continually updatable and policy units have the capacity to understand how things are changing from a monitoring and evaluation perspective. And we've published, say, a big dashboard on hospital productivity, which is accessible to the public and accessible to clinicians and hospital managers to kind of really see where productivity is and how individual sites kind of compare to others. And then tailor communications. I think it came up before that when you're trying to brief a minister or a secretary general, they are very time poor individuals. Their ability to take very long briefs is probably going to be constrained. So are you able to say everything you need to say within 1 page or maximum 2 pages with bullet points? So that's kind of some of the reflections, and I'll try and weave some of that into maybe the case study now. The new policy is, so just, I suppose, again, kind of chiming with some of the stuff that's gone on earlier. When you get a request, it's generally there's a demand there for some sort of evidence base, and I would echo the RESA results, where the demand within the department from the senior leadership, from the political leadership, is very high. So there is a real demand for evidence to inform policy making. Then there's the challenge where the knowledge brokerage comes in, of transforming that demand into need. So how can we best fulfill this demand? What types of evidence might usefully support the policy-making process? And are we able to deliver that within the time constraint that's available? So sometimes these constraints can be, what have you got by lunchtime? What have you got by tomorrow? What have you got by next week? Or it could be, we're working on a 9-month project to feed into the budget, or even longer. And then some of the considerations around that, you have to have an understanding of your own capacity, what the data sources are, what the skills base within the department is, and what the technology available in order to kind of make progress is. And when you put all that together, you'll have an understanding of whether a particular research project should be done internally, given a certain level of sensitivity around it, or a certain time pressure around it, or maybe it should go out externally to Health Research Board evidence for policy, or evidence synthesis work, or the ESRI. So that kind of informs whether or not stuff gets done in-house or out-house. So then the sort of more case study on general practice. I should say that this work has largely been driven by Deirdre Coy, who again is kind of came out of the Sphere program. So we've really benefited from the kind of injection of academic level kind of research skills into the department. But the first phase was probably back in about 2022, and we were asked a very simple question by the SecGen, which was, how do we expand eligibility to GP visit cards? So at that time, eligibility was being rolled out on the basis of age, and there was some concerns in the department around that approach, around whether it was really addressing the health needs of the population. And there was also the inflation kind of cost of living issues arising from the Ukraine war and COVID. Then the phase 2 was a strategic review of GP services, which happened after the extension, where we transformed some of the knowledge into a major publication, which allowed us to inform the strategic review of GP service. Then the ESRI this year have published projections of the demand for GP services as part of a capacity review that was undertaken. And now we're looking at the gap between eligibility and uptake. So I suppose there's Sláintecare commitments around access to GP services. And there was at the time in 2022, there was a program for government commitment to expand universal access to GP care. So there are different ways that you could do it: income, age, co-payment. You had to have a view of the impact on current capacity and the induced demand that might result from transforming people from private patients to public patients. We relied on a lot of work that had been done in academia that looked at, say, the extension to under sixes. And Teresa McDonnell had done some work on what the induced demand effects from that was. And this is kind of an important point, because at times when you have to do something quickly, you kind of rely on the evidence that's been accumulated externally and maybe take some of that in and use it as parameter values. And then we also drew on the WHO cube, which is kind of a nice way of looking at how you achieve universal access to services, and it kind of across the dimensions of population coverage, the services coverage, and the cost of it. So as part of it, we did a multi-criteria analysis of the different options against kind of different policy considerations. This is a nice way of kind of evaluating against multiple different objectives, which always kind of exist in a policy sphere. I suppose then you also have to make recommendations, as I said. So in the end, we came down on the expansion by cost. I suppose in the context of a cost of living crisis, the ability to hit equity concerns and target undue hardship loomed large. We were aware from kind of Healthy Ireland surveys that one in 5 people were not accessing GP care because of cost considerations. So we kind of costed various different rollout scenarios, and then those had to be negotiated with the ICGP and others. So that kind of brought us into the strategic review of GP services. So following the kind of expertise we developed in the unit as a result of that, there was a terms of reference published for the strategic review of GP services. It kind of laid out very clearly what the evidence requirements for the review were going to be. So we were able to match those evidence requirements to the research that we had undertaken. And we published that in June of this year. And again, Deirdre and Manor kind of led out on this work. So I talked a bit about data challenges. So just to show you the kind of imperfect situation that we work in. So you're trying to splice together different data sets from different areas. You're looking at PCRS data from the HSE on who are the public GPs. Cervical check data gave us the nurses working in GP practices. Population census, Healthy Ireland for visits. And then you're trying to put that together with the international literature and the Irish literature in order to be able to understand what the variations in kind of visitations and whatnot are. So for the first time, we were kind of able to answer kind of how many GPs we have, which there was a range of different estimates. It kind of speaks to that point of you think certain things would be knowable, but actually it takes a good bit of work in order to get to an agreed position. So we have to thank our colleagues in the statistical unit who helped us with these maps, and I think it's really good talking about the different disciplines that are involved in policy making. Bringing geography back in because a lot of services are delivered locally, so being able to graphically represent that is kind of really important. So we have the GPs. There's about 3,200 practicing GPs, and then we can see where they are across the country. And then with the nurses, about 2,200 practice nurses, and again, you can see that. Then we kind of applied the different visitation rates by age, and we were able to see like where maybe some of the supply constraints were, and you would have heard those in the kind of news. Like overall, we have a good level of supply, but in certain areas there are probably issues. And then when you complexity adjust it for the time taken for visitations, you're able to get the map on the right, which actually means that some of the areas that were maybe more problematic become less problematic. So then one of the big questions in the review is the risk of retirement. There's been a narrative that a lot of our GPs are set to retire. Actually, the pipeline of new GPs is very strong, and the risk of retirement is no different from any other profession, but there are localized issues in certain areas. And particularly, that would be a risk where GPs are working in single practices. So having a knowledge of where those issues are allows the HSE to better match individuals to areas where there might be an imminent retirement. So then into the capacity review, Sheila Connolly and Tiano and all did publish this paper during the summer. And this provides demand projections out to 2040 for general practice. And as you can see, there's a significant increase in demand, up to 30% for GPs and up to 36% for practice nurses. And there's a lot of assumptions within that around demographic change, around healthy aging. But just to focus on one of the assumptions, which is on income-based eligibility uptake. So they modeled a 70% uptake of those already covered by the eligibility, and a 50 to 70% for newly eligible. So that kind of sets the scene for the work that we're doing at the moment, and this has kind of been brought out by Claire Delargy and Aaron Deegan. So we're looking at that gap between eligibility and uptake. So on an age basis, pretty much everybody takes up their cards because they know what they're entitled to, and it's straightforward to get. But when it comes to income, the uptake is much lower. So we estimate maybe there's only about 40% uptake of GP visit cards, leaving over 300,000 people who have an eligibility but not availing of their eligibility. So we're approaching this problem in two ways. The first is around a sludge audit, which is a behavioral science tool to identify, reduce, and prevent unnecessary friction in the process for applying. So it's really going through the process, understanding what the service user experience is within that, mapping out the number of steps that are required, how easy, rating how easy or complex it is to fulfill the requirements, and the time it takes. So as you can see, in order to get a GP visit card or a medical card, there's a lot of steps. It's quite difficult to approach, and if you have poor health literacy, that can be a big barrier, and it's quite time consuming. So we're using this to see whether there's parts of the process that could be simplified, and like one thing could be, an eligibility calculator online that people can readily assess whether or not they're eligible. But kind of more long term, we'd like to see whether we'd be able to award people their entitlement based on linked up admin data. So really, the state now holds quite a lot of information on people in a very secure environment, I should add. But we've benefited greatly from the CSO's kind of new project on virtual data rooms. So we've been able to link census data, revenue data, HSE data, and social protection in order to get kind of nearly 500,000 observations on individuals. And then we're really trying to see if we can identify people who should have a card but don't have a card based on the characteristics that we're able to observe. So this is very preliminary, and I should say that it hasn't been kind of social or kind of tested fully. But we looked at medical card first because the eligibility for medical cards are actually quite clear. So because the thresholds haven't been adjusted for a while, there is a rule that if you are exclusively on social welfare, you should obtain a medical card. So from the sample that we have, about 10% of the people who would be eligible for a medical card based on that social welfare rule do not have a medical card. So if you gross that up to the population, we're working at a 10% sample, that could be about 150,000 people. Now, of those, about a quarter have a GP visit card, but I suppose the GP visit card allows you access to GP services, but it doesn't come with the full range of benefits that a medical card would hold. And we can see that the age is a factor, like a lot of the sort of middle-age people who mightn't use a GP as frequently are maybe not availing of the medical card. So potentially this is because they're actually in quite good health. So because we have that link to the census, we can see that over 80% of them are either very good health or good health, self-reported. So perhaps there's an element of need there. Maybe they don't go to the GP all that often and they don't feel the time commitment of 11 hours is worth it. But actually this is an entitlement that they have, and health status can change quite quickly. So should we make more efforts in terms of bridging that gap? The next steps for this work is to try and test that approach against the GP visit card, where the eligibility criteria is a bit more complex. It doesn't have that simple rule. But would we be able to determine people who are quite similar, some of whom have cards, some of whom don't have cards, and then maybe simplify the eligibility criteria with a degree of confidence and just provide them with cards? So that's kind of the work that we're doing on the implementation side to try and close that gap. So I'll leave you back with that slide around what works and what doesn't work, or what's worked for us. And I suppose all of this research kind of came out of a very simple request. And if you're successful at meeting that request, you could then get additional requests and additional demands, and that becomes a challenge too. But it's a good challenge, and one that allows you to kind of achieve greater impact from evidence-based policy making. Okay.